All right, we'll give people a few minutes to start getting in, but we have no announcements this week. You'll notice you have a new host this week, our capable Associate Chair of Communications, Dr. Elzaga, is not with us today, so he'll be back next week. The rest of us will see if we can, with our combined efforts, muddle through to try to replace Errol, which is a tough thing to do, as I think all of you have been coming to medical grand rounds for the last few years now. We're really excited today to have one of our own faculty members, Dr. Yuri Ladabaum, presenting with us today. And with that, I will turn it over to our Division Chief of Gastroenterology and Hepatology, Dr. Ray Kim, to introduce Dr. Ladabaum. Thanks, Ray, for being here.
Certainly. Thank you, Bob. Good morning, everybody. I have the pleasure of introducing my partner in GI division, Yuri Ladabaum. One of the reasons why we do this is March is a colon cancer awareness month, and think everybody, whether you're up to date in your colon cancer screening. So if you're not, you need to do something about it this month. So Yuri serves as a director of GI cancer prevention program and heads the clinical services for the division. He received his medical degree from UCSF, completed his residency and chief residency in internal medicine right here at Stanford University, and did his fellowship at University of Michigan. He also has a MS degree in clinical research design and statistical analysis. His clinical practice includes providing consultation and endoscopic services for people with average or high risk cancer, including colon cancer, and caring for patients and families with suspected or established inherited cancer predisposition syndromes. His research focus is related to that, colorectal cancer risk management and prevention. His current and recent areas of investigation included risk stratification and personalized screening, cost effectiveness, regarding multiple questions related to screening, quality of monitoring for colon cancer screening, assurance in quality assurance in endoscopy, safety, and identification and management of families with genetic cancer syndrome. He has been a true leader in the division, and I am really pleased to welcome Yuri, whose topic is going to be colorectal cancer. Screening has come of age. What is next? Yuri?
Thanks, Ray. Very kind introduction. I will put up my slides and we can start the discussion. Okay. So as Ray mentioned, colorectal cancer screening has come of age, and the question is, what's next? I wanted to start by asking people if they recognize this table. You'll see that the columns have specific subgroups on the left, pregnancy in the middle, all people in the population of a certain age in the right. There are some cross-cutting themes horizontally, stopping and screening for tobacco, HIV-related, syphilis, and then there are a few other things scattered. And at the bottom on the right, you'll see screening for colorectal cancer recommended for all people in the population of a certain age, middle to older age. That's the only recommendation for all people of that age. Well, some of you may know that is the USPSTF recommendations list for grade A recommendations. What does grade A mean? It means that there is a high certainty of substantial net benefit in the mind of the task force. And there are only 14 of these recommendations. Grade B, not quite as strong, is when there's high certainty of moderate net benefit or moderate certainty of moderate or substantial net benefit. And there are 39 of these. These recommendations have the force of law. Under the Affordable Care Act, these preventive services have to be covered by CMS. So if we look back at the list, this is the only cancer for which the task force thinks all people of a certain age should be screened. It's a unique thing. And most recently, you must be aware that the screening age was lowered. Screening in the late 40s is a grade B recommendation. This is my agenda for today. I'd like to cover with you where we've been, a bit of history on how we got here, then talk about where we are and what is the key supporting evidence for today's practice. And then there are some next generation questions. We'll look at the future. Can artificial intelligence be a revolution in the quality of endoscopy? What about novel tests that are emerging? And what is the promise of personalized screening? So let's look at a little bit of history. A landmark study from England, from the pathology database of St. Mark's, came out in the 1970s. And they basically took a look cross-sectionally at all the pathology specimens they had in the colorectum and asked, what are the ages of these patients, and can we begin to tell a story? And one of the very important observations was that they had some adenomas that had the beginning of cancer. So cancer can arise in an adenoma. We take this for granted, but these observations had to come from somewhere. This is a 2-centimeter adenoma, and in the center, you can see disorganized tissue beginning to invade through the muscularis mucosa. That's cancer. The other thing is that most adenomas probably don't progress to cancer. The number of cancers are much fewer than the number of adenomas in the population. And by the general ages at which people had adenomas versus cancer in the database, this initial sense that it can take many years from adenoma to cancer came about. And that is the beginning of this rule of thumb that people say, oh, it's about 10 years. Now let's look at the birth of screening. David Grigor was a very enterprising primary care physician who said, well, I wonder if I could test my patient's stool for hidden blood. And he did this in thousands of people, found 7 patients who had cancer and had had positive tests. So that's the beginning of stool testing, just by being creative in the primary care setting. And Gilberstein led a rigid sigmoidoscopy effort where he basically did rigid proctostigmoidoscopy at the time in thousands of people and found that they didn't get cancer. He found polyps, took them out, and then they didn't develop cancer. It is now very well established that most colorectal cancers arise from polyps. And initially, on the left of the slide, you see there's hyperproliferation of cells. Eventually, you get a small adenoma. Now we know that sessile serrated lesions are also risk for cancer, but you get a small adenoma or SSL. These grow, they develop more and more genetic changes. They can develop severe dysplasia. Eventually, you get a localized invasion in the polyp. If it's a polyp with a stalk, you can cure the cancer by removal. If it's a sessile polyp, it's more likely to invade and look like what you have on the right, which is an invasive cancer. So this sequence provides us the opportunity not only for early detection of cancer, but prevention altogether, if we can find and remove the cancer precursors. Which means to me that colorectal cancer screening may not be the right term. I actually would prefer to be talking about colorectal neoplasia screening, where we're talking about the cancer precursors, but I don't think I'm going to win that semantic fight. With that history, then, let's look at the key supporting evidence that leads to today's recommendations. A landmark observational study came from Kaiser Permanente in the 90s, and they basically asked the question, among patients who are diagnosed with colorectal cancer and among controls, what was their previous exposure to sigmoidoscopy? And the association of distal colorectal cancer with exposure to sigmoidoscopy was very protective. Odds ratio of 0.41 for people with sigmoidoscopy exposure. In the proximal colon, there was no difference. And that's, of course, the segment not reached by the sigmoidoscope that essentially, if you look at the figure here, goes into the rectum, through the sigmoid colon, and a variable distance into the descending colon. Next came the National Polyp Study. And this was a study that took patients with polyps, did very careful exams, removed all the polyps. Some people had 2 colonoscopies, and then followed these patients over time. There was no control group, but there were historical controls. And the question is, how many cancers are observed after you clear the colon from polyps? The bottom curve on this graphic on the left is the number of cancers observed through 7 years of follow-up in this study. And you can see that that curve is much lower than the middle external control, the number expected from SEER, or the numbers at the top estimated from data from Mayo Clinic and the St. Mark's data. I showed you the pathology data from St. Mark's. So the conclusion from this landmark paper was that careful exam with removal of polyps could potentially avert up to 76 or 90% of colorectal cancers, a very large fraction. The lead author of this paper, Sid Winower, is truly one of the pioneers and leaders in this field, and I'll have more to say about Sid later. If we look at around the same time, the randomized controlled trials of guaiac-based fecal testing were starting to mature. And these were enormous efforts in the United States and Europe. Tens of thousands of patients followed for over a decade with multiple offers to undergo stool-based screening. And the summary of the results are here. With annual FOBT, there was a 33% reduction in colorectal cancer mortality. With biannual FOBT, the numbers were a little lower. And other studies with longer follow-up also showed a reduction in incidence. Over a decade later comes the evidence for endoscopic screening. And these are enormous screening trials, randomized controlled trials for flexible sigmoidoscopy, again, in Europe and the United States. Median follow-up in these, you can see, is about a decade. And in an intention to treat set of analyses, the incidence reduction of colorectal cancer, so this is prevention, about 20%, mortality reduction greater than that. And in per protocol analyses, if you look at the patients who actually got screened, incidence reductions about 30% plus, mortality reduction in the 40s. And again, this is just in the left colon because the sigmoidoscope doesn't reach all the way around. Now, a remarkable thing is that if one performs a meta-analysis appropriately stratifying the results of one of this trial, the NORCAP trial, you actually see a reduction in all-cause mortality. This is absolutely astounding. There are very, very few things in the prevention world that have data for reduction in all-cause mortality. So the evidence basis here is extraordinarily strong. Now, if I could see all of you, if we were in one of these old-fashioned rooms and I said, who believes in evidence-based medicine, please raise your hand. I think all of you would. And then I would ask you, okay, great. Who promotes guaiac-based FOBT or sigmoidoscopy as the main test for colorectal cancer screening? And of course, that's an unfair trap because we essentially extrapolate from those studies, combine that with observational studies, and we end up where we are today, where the primary screening modalities are the fecal immunochemical test, not the guaiac-based test, and colonoscopy, not sigmoidoscopy. The USPSTF recognizes this. The menu of options include a high sensitivity guaiac-based test, but really most settings include the fecal immunochemical test, which is more sensitive and specific. There's also the stool DNA FIT combination, which in clinical practice is every 3 years. There's CT colonography, flexible sigmoidoscopy, combination of FlexSig and annual FIT, which does not have much direct evidence behind it, but it ends up on the list, and then colonoscopy every 10 years. So until very recently, our summary of the literature for FIT and colonoscopy was based on observational studies and studies of test characteristics with estimates of benefit that were better than guaiac-based testing or sigmoidoscopy. And then the Nordic trial hit the news. So this was at the end of last year. There was a lot of press coverage of this, and I think it's important to discuss the key aspects. First, the strength of the study, but something we also have to understand in order to interpret it, is that it is truly a population-based invitation. So there are people out there who get a letter, would you consider doing a colonoscopy for screening? And the control is usual care, which is remarkable. These are Northern European countries that are not resource poor, and their standard of care when this was launched was still not to have colorectal cancer screening, despite all the evidence that I showed you. The ultimate participation rate in the intervention arm was 42%. So is this good? Is it bad? Is it reflective of other places? Can you extrapolate? That's a judgment call. And these are the interim 10-year results. The sample size and power calculations call for a plan of 15 years. Now, this may have come and gone, so some of you may or may not have paid attention to this, but this was huge in the news, and it was reported in a way that really lacked nuance and didn't understand what was going on. Colonoscopy may not be as effective. Do you really need a colonoscopy? Doctors push back. So let's look at the results and see what all of this was about. These are the curves in the intention to treat analysis for colorectal cancer incidence, where the invited group is in the red, the usual care group is in the blue. You'll notice that initially the quote incidence is higher in the screening group. Well, screening cannot cause cancer, So what is happening here is the detection of prevalent asymptomatic cancers. That's the initial bump in the red. Then you'll see that the slope of that red curve flattens compared to the blue, and that's prevention. That's the result of polypectomy. So this is a very, very classic pattern. I'd like you to remember this. You'll see it again. Initially, you uncover the prevalent cancers. Ideally, those are earlier stage, and so you have a benefit from the start. And then there's the flattening with respect to the no intervention arm because of polypectomy. This reflects the screening participation rate of 42%. The risk ratio here is 0.82, or an 18% reduction, and that is statistically significant. But the mortality curves are different. They basically are intertwined. They essentially look the same. And the risk ratio here is on the side of benefit, 0.90, but the confidence interval crosses 1. So no statistically significant reduction in mortality in the interim analysis of the Nordic trial at 10 years, even though the FLEG-SIG trials did show benefit in around a decade. So at this point, one begins scratching one's head. What's going on? Now, if you look at the adjusted per protocol analyses compared to the intention to screen analyses that I just showed you, the numbers are more encouraging. In the adjusted per protocol analysis, CRC incidence reduction, here the ratio is 0.69, or a 31% reduction, and mortality reduction, 50%. But this calls for a comparison between the Nordic trial and the FLEG-SIG trials. What is going on? I mentioned to you that I'd show you this pattern of uncovering of prevalent cancers and then flattening of the curve. These are the 4 FLEG-SIG randomized trials that you saw in tabular format before. And the pattern here is the same in every study. You uncover the prevalent cancers, then there's flattening with screening. There's a crossover of the curves at 3 to 5 years. And this is consistent across all of the FLEG-SIG trials. So Nordic looks like this. But what about the mortality curves? The mortality curves in the FLEG-SIG trials are different. Nordic does not look like this. You begin to see a separation in the mortality curves almost from the start, with screening showing benefit. Now, it takes a while for there to be power to demonstrate that these are statistically significantly different, but there's benefit from the beginning, which begins to get to the issue of uncovering of the prevalent cancers at an earlier stage with treatment leading to better outcomes than waiting and basically finding those cancers at more advanced stages. So these curves are textbook curves, and I can call them textbook curves because the editors of the textbook of Yamada GI allowed me to create an idealized curve from these 4 and say, this is what screening looks like. This is what endoscopic screening looks like. So if we compare Nordic to the textbook curves, the incidence curve has the same shape. The mortality curve does not show the same thing. I don't think we totally understand this. I wish I had a perfect answer for you. I don't. I'll get back to this and make some comments about this later, but this still remains a big question for me. Now, what has happened in the US? Well, we've been doing screening for several decades now. These are the SEER data for colorectal cancer incidence as a function of age in the early 90s. You can see that cancer incidence rises as a function of age. It begins to accelerate around age 50 in these data. And this is what led to the recommendations to start screening around 50. Things have changed a lot over a few decades. The risk of developing colorectal cancer at older ages, 55 and above, has gone down dramatically. We cannot prove that all of this is from screening, but we think a lot of it must be, particularly because the risk in younger people has gone up. So this is a very, very strange looking curve in 2015 compared to 1993. And it just gets more and more accentuated this way the closer we get to today's calendar year. The risk in younger people is going up. The risk in older people is going down. So you have 2 very different environmental things going on here. There's something increasing the risk in younger people, maybe diet, obesity, childhood obesity, diabetes. We don't totally understand this, but those are some of the suspects. And then in the older age groups, the risk going down, most likely in large part due to screening. So the USPSTF took a look at the evolving data in younger people. There's the expectation that screening will perform as well in younger people as in older people. And then there were modeling studies. And based on that, they said screen age 45 to 49, grade B recommendation. There wasn't a lot of data to back this up at the time. It was really the epidemiology, modeling, and the expectation that lowering the screening age should work. Since then, investigators, including our group, have started to fill in the data. And one study that our group is very proud of was led by Manny Segal, who was actually an undergrad when he did this. And we had access to data covering almost all the state of Florida, where we knew who got colonoscopies, and then we asked who got hospitalized or who came to the emergency room, ultimately with a diagnosis of colorectal cancer, to look at the association between exposure to colonoscopy in the late 40s, contrasting that to the early 50s, and subsequent development of colorectal cancer. And we found what we expected and hoped, and that is that those people who got exposed to colonoscopy in their late 40s had an adjusted hazard rate of developing colorectal cancer of about 1/2 compared to those who didn't. So I think when the next iteration of the USPSTF comes around, there'll be more data. There are other studies that have been published with the same message. Exposure to colonoscopy is associated with lower subsequent risk. It's what you would expect, but we're now getting the data in this age group. So I think you can see that the data are very strong, the practice is firmly established, and then we face these next generation questions. I mentioned I go back to Sid Winower. Sid famously said decades ago, the best test is the one that gets done. There were many gastroenterologists who said, oh, everyone must have a colonoscopy. There were many enthusiasts of the non-invasive test, stool test, saying, no, colonoscopy is crazy as a screening test. Sid was very practical. You need uptake, you need participation. The best test is the one that gets done. But in his summary of the history of colorectal cancer, which is where I learned a lot of what I showed you in the early slides, he modified his saying. What he wrote there is the best test is the one that gets done and done well. And then he also had this other sentence that I pulled out. Colorectal cancer screening is evidence-based, but resource-driven. I love these two quotes from Sid, and I'll tell you why. I think they completely capture the state of the field. Evidence-based, that's the science that I showed you. It's extraordinarily strong. The test that gets done is participation. If people don't do it, we have no public health impact. Done well, quality. The quality movement has been huge in colon cancer screening and in colonoscopy specifically. And then the question of resource-driven brings up thorny questions about ethics and economics. So with these two sentences, I think Sid Winower captures the entire status of this field, and I think one can extrapolate this to other areas. I showed you the science, extraordinarily strong, USPSTF grade A. So now let's look at some of the other questions. And the next thing I want to focus on is quality, because this has been a big movement in colorectal cancer screening for the last several decades. Let's talk about the adenoma detection rate. This has become the primary quality metric for colonoscopy. It was originally defined as the fraction of first-time primary screening colonoscopies with at least one adenoma detected. So this is important. This is not, of all the adenomas out there, how many did I find? To some extent, that's unknowable, right? What's the gold standard? This is basically saying people are walking around with a certain prevalence of adenomas. From the 40s into the 80s, that's maybe from 1/3 to about 1/2. It goes up with age. So people have these polyps, assuming that that washes out from my practice to Dr. Smith's practice to Dr. Jones's practice, then we should all be about the same. And so how many of our colonoscopies are we finding adenomas in? And this goes back to the whole notion that we want to find adenomas before they turn into cancer. So this is a metric of how good are we at finding potential precancers. Not all adenomas go on to cancers, but most cancers start out as polyps, either adenomas or cell-serrated lesions. This was first proposed in 2002 by Doug Rex, just based on logic, saying, I think this makes sense. And it took almost a decade for a landmark publication in the New England Journal, where the Polish colonoscopy study investigators demonstrated that there was an association between a colonoscopist's adenoma detection rate and his or her patient's chance of showing up with cancer after the colonoscopy. I'll show you a curve in a moment. 2014, the second landmark study from Kaiser Permanente in Northern California, basically demonstrating an association between adenoma detection rate and inverse association. The higher adenoma detection rate, the lower the risk of post-colonoscopy colorectal cancer incidence and mortality. So this is the curve from the Kaiser study. We have higher and higher quintiles of detection in the x-axis. So those are colonoscopists who are better and better and better from left to right at finding polyps, and the adjusted hazards ratio of their patients dying from colorectal cancer on the y-axis, that curve goes down. This is the conclusion. The higher your colonoscopist adenoma detection rate, the lower your risk of dying from colorectal cancer. This is not a small thing. You want to be scoped by a high detector. And now we have greater and greater granularity. This is again from the Kaiser system, looking at smaller and smaller slices of the adenoma detection rate. The first benchmark proposed was 25% or higher. And that was very permissive. That was basically just dipping the toes in the water. But you can see that the post-colorectal cancer cumulative incidence on the y-axis keeps going down and down and down and down, well into the 40s of detection. So the new benchmarks are probably going to be higher. A colonoscopist with an ADR of 25% should not rest easy saying, oh yeah, I meet the benchmark. That is not good enough compared to what it could be. So this brings us back to Nordic. Some of the results in the Nordic trial are not what we would expect. And one of the things you can ask is, what was the adenoma detection rate in this landmark colonoscopy study? And we're not going to have other studies like this, where there's going to be comparison between colonoscopy and no intervention. There are ongoing trials between colonoscopy and FIT. One of those is in the VA system in the United States. So this was from the initial publication in Nordic. They didn't have the outcomes yet, but they said, what happened when we colonoscoped our people? This came out in 2016. And what they said is that among the 32 endoscopists who had at least 30 exams, so that's a select subgroup, 29% of them had adenoma detection rate below the benchmark of 25%. And you can see the scattergram here. So those are low detecting colonoscopists for whom you would not expect a very good result in terms of finding adenomas, preventing cancer, and maybe they were even missing cancers. Now, one question that I have is, these are 32 endoscopists, at least 30 exams. So the math there is at least 960 colonoscopies accounted for by these 32. But there were 12,000 colonoscopies in Nordic. What is the quality among the other endoscopists? That is something that's not clear. If we look by country, on the ultimate publication here that did not include the Netherlands data for technical reasons, the adenoma detection rate, 30% in all participants, that doesn't look bad. In Norway, 27%, probably lower than expected in a country that has high rate of cancer. Poland, good, 35. Sweden, not so good, but that was a very small fraction of the trial. So there are issues with Nordic. I don't think we know all the answers. Adenoma detection rate may be one. Now I want to take a little detour related to the adenoma detection rate. And this goes back to when I gave grand rounds here at Stanford in August of 2012. These were some of the slides that I used then. I told you that the Polish data came out around this time, 2010. So the quality movement was getting evidence, and ADR, adenoma detection rate, was very important. So I got a very pointed question in the QA section. What are our adenoma detection rates here at Stanford? And I didn't have a good answer. This is a seemingly simple ratio to measure, but it's actually not that easy to do. I had some sense that we were probably doing okay as a group. We had a study, 4 of us as colonoscopists, looking at withdrawal time and what we were detecting. So in that research setting, I thought we were doing okay, but I didn't have a great answer. And I said, I hope if you ever invite me to talk again about this, that I can give you a better answer. So here we are today. We have made tremendous progress. I'll show you our timeline in a second, but we've gotten to the point where I thought, okay, I'm proud enough of this that this deserves to go on our website. Our group's adenoma detection rate, 44%, which is very good. You can compare that to the curves that I showed you before from Kaiser, well above the very permissive benchmark. And I'm very proud of our colonoscopy quality assurance program and of the performance of our faculty. The credit really goes here to our entire group for caring about quality and for documenting appropriately so we can actually query this. So the history of this I thought was interesting enough that I thought, let me try to get it published. And the editors of Gastroenterology were interested because it's not easy to measure quality, and to marry quality improvement with research is the next level. And so you'll see here in this timeline that we started thinking about this in 2010. In 2011, we had bad systems, imperfect attempts to monitor imperfect surrogates. August 2012, I get the question in grand rounds, what's our ADR? 2014, national developments and institutional priorities aligned. I got resources from the department and from Stanford Hospital to actually do this. We built our audit system, and we're at a point now where we are publishing on this. So what are the adenoma detection rates at Stanford? I hope to be able to tell you if I got invited again. So here we are, and I'm happy that I can keep the promise. So let me show you graphically some of what this has started to yield. So the first time screening adenoma detection rate, if you were to build an audit for just the basics, this is all you would have. And this is from a certain period of time before that 44% that I showed you. But we constructed our routine documentation so that there's no double data entry. If our doctors do the colonoscopy report a certain way and send their pathology results letter a certain way, then we can extract data and we got everything we want. And so we know our detection rates, not only in first-time screening, but in subsequent screenings, in surveillance post-polypectomy, family history, people who have abnormal fecal tests, or follow-up from other things. We also know other lesion detection rates, advanced adenomas. These are the ones that are closer to cancer. The cell-saturated lesions, which are harder to detect, and are the other cancer precursors. So these type of data are very important, and I think they will inform the next iteration of recommendations of the adenoma detection rate. What indications should be included, and what should be the benchmarks. So we are not the only group that has this, but there aren't that many places that have granular data, and I think this will contribute to national policy. The other thing we did recently is to say, all right, we're starting to screen people in their late 40s. What are we finding? Were the projections right? Should we be doing this? And you'll see that in the red are people who came in for first-time screening in the late 40s, as just recommended by the USPSTF. And we compared that to people in the blue. It's been the standard of care to start screening in the 50s. And the other thing we did is to say, what about people who come in for their second colonoscopy in their 60s? That's also accepted. Screening colonoscopy, if you do it every 10 years. So we're screening people in their early 50s. We are rescreening people in their 60s. What is the yield of screening in the late 40s? And remarkably, it's pretty similar to screening in the 50s, a little lower for adenoma detection and cell-saturated lesion detection, you'll see, but not statistically significantly different. Advanced adenomas, comparable. So they seem to be there already in the late 40s. And then if you look at people in their 60s who are coming in to rescreen, they're already a lower risk group because they are the subgroup of those who came in the 50s who had a normal colon. So they're not in surveillance, they're not in post-polypectomy, they're just coming in for their second colonoscopy, and they're lower risk than the other 60-year-olds who either have not been screened ever or who had polyps. And their risks of lesions are about the same as in the late 40s. So it's, I think, additional evidence that it makes sense to have lowered the screening age. Now then, let's talk about participation. Because the ultimate effectiveness of screening, even if the modalities are very efficacious, the ultimate effectiveness is determined by participation. And so I'll remind you that in the Nordic trial, 42% of people participated. The intention to treat results reflect this participation rate. We have to get people to do this. We have to get people to do this well, quality, and we have to go all the way if we do two-step screening with non-invasive tests. These are data for Kaiser looking at potential modifiable failures in the process of screening. And what we're showing here are the relative risks of death from colorectal cancer if various things happen. Now, down at the bottom, if you're up to date with screening, your risk of colorectal cancer death, 0.38. So as Ray said, if you're eligible, screen eligible, this is Colorectal Cancer Awareness Month. If you're not up to date with screening, please get up to date with screening and get your patients to get up to date with screening. That's the protection at the bottom. But if you look at the top, if you were never screened, so failure to ever screen, your risk is 2.5. If you're not screening at appropriate intervals, 2.4. If you're not doing surveillance the way you should post-polypectomy, 2.2. If you fail to follow up with colonoscopy after a positive fecal test, 7-fold. Let me say that again. Fail to follow up with a non-invasive test, risk is 7-fold. This makes sense. These are people with blood in their stool. These are people who are more likely to have cancer already or advanced polyps. If you do not do a colonoscopy in them, the failure of the system is inexcusable. And we used to say the follow-up rates in colonoscopy are not good in safety net settings. We need to get better because the data came mostly from these resource-constrained and more challenged settings. But more recently, we're getting wake-up calls. This is a very important publication that just came out. What is the colonoscopy follow-up rate after abnormal fecal testing among commercially insured patients? And this is across 39 health systems. The average is 56%. That is awful. And this is a big wake-up call. So for those of you in primary care, think about what you think your rates are, because the doctors who got surveyed in this study, they were all surprised. They all thought, oh my God, I thought we were doing better in our system. We don't know until we measure it. So I don't know how we're doing in our primary care setting here, but I think we need to look at this. The AGA, the American Gastroenterological Association, recently came out with some position statements on reducing the burden of colorectal cancer. I was honored to be part of this group. And one of the things that we laid out was looking at a future where we have more and more non-invasive tests. I think colonoscopy is a good option, but it's not the only one. And there are some patients who will never do screening colonoscopy. So we need choice and we need discussions with patients. They need to screen the way that is good for them. But if one goes to a non-invasive paradigm, then potential quality metric is how many patients do that. If the non-invasive test is negative on the left, then they have to come back and do it again, right? You have to be up to date with the intervals. So potentially this is a more rigorous program. You got to do it every year, or if it's Cologuard every 3 years. If you do a colonoscopy and it's normal, you're out of your doctor's concern and your own concern for screening for 10 years. Now in the bottom right, you'll see if you have a non-invasive test that's positive, what's the percent who completed a colonoscopy? We think this should be a quality metric. It isn't now, but it probably should be. Now back to the issue of participation. It takes a while to build up participation, and it plateaus in the low 60s. Once people have Medicare coverage, even then, we haven't been able to move the needle below the low 60s. And in the US, it's mostly colonoscopy, some fecal testing. Part of the rationale to lower the screening age is also, well, maybe we start this ramp up even sooner. People start hearing about this sooner. We get some people in the late 40s, and maybe we get more people in the early 50s. They're already, quote, late, but they're not as late as they would be if the starting age remained at 50. There are many barriers to screening. Some are at the patient level, some are at the system level, and some reflect inequities, which is just intolerable, but that is the reality. There are some interventions that are proven to help. General practitioner recommendations, outreach definitely makes a difference. Mailing fit tests to people's homes improves participation. Reminders, and the sociology-minded researchers who look at this have developed a vocabulary of human behaviors. There are people who are consistent attenders. There are non-attenders. There are non-responders, people who don't even reply to you. There are active decliners. Thank you very much. I don't want to do this. And the participation patterns can either be consistent over time. There are so-called late entrants. There are people who drop out. There are people who are in and out intermittently. And then there are the never screeners. So all of this and thought about the barriers brings up these issues of ethics and economics that we cannot delve into much today. But I do want to acknowledge that in this whole area of preventive care, screening, there are social issues beyond the scientific issues. There are ethical issues about access, about autonomy, about informed decision-making, and then we have to contend with human behavior. The English bowel screening program actually deals head on with the possibility of opting out of screening. This can be done. They have some warning language here, make sure you've thought about this, but people can be removed from the screening list in England. I would say that for the system to be serving people, we have to do our best that people understand what they're doing. This can't be because of lack of education or lack of access. But if you really understand and say, great, I get it, I don't want to be screened, all right, it's your autonomy. Let's look at the future now. Artificial intelligence is everywhere now, discussions of this. And I'm showing you now a little bit of dirty laundry here. This is our individual doctors' adenoma detection rates on the left. And then the next panel on the right is what we called the adenoma detection rate extended to all screening and surveillance. I showed you that we can now audit for all the indications. So here we said, let's put together all the preventive interventions that increases the sample size per doctor, narrows each doctor's confidence intervals. And so even though I'm very proud in our website disclosure that our group's detection rate is really very, very good, we have a spread of detection rate among our practitioners, as does every system. And the onus on us, on everybody else, is to say the top performers, great. The middle performers, can we nudge you? Can you get a little better? And our lower performers, can we really get you up to better ranges of the adenoma detection rate? But the message is colonoscopy is highly operator dependent. And that being the case, researchers are starting to ask, can artificial intelligence come to the rescue? Are there polyps on the screen that we as humans are not seeing? And the computer can say, look there, computer-aided detection. There's a polyp. Now, a few years ago, this seemed like science fiction, but nowadays, we all have this type of recognition, and you probably used it today. You probably opened up your mobile phone like this today. So if this can be done, recognizing your face, why not recognize a polyp in the colon? And the answer is yes, it can be done. There are now meta-analyses of randomized controlled trials that show that most of those studies demonstrate a benefit for computer-aided detection, or CAD-E, compared to no CAD-E. And this is a very important paper that came out from Italy on the GI Genius technology by Medtronic, which is commercially available in the US. And you'll see that in the blue bars, the detection rates for any neoplasia on the left, which is basically any adenoma, that's the adenoma detection rate, into the 50s compared to 40 with use of computer-aided detection versus usual care. And these are significant for everything except the larger polyps, which frankly are the ones we care the most about. That's the greater than or equal to 10 millimeters, where I have not significant. You see there, the relative rate is 1.07, so in the right direction, but the confidence intervals cross 1. So we had the opportunity to test these devices. You basically just hook them up. When you do colonoscopy, a little green box comes on where the computer says, hey, look here, that could be a polyp. So we hypothesized that we would replicate the results of the study by Rapici and colleagues that I just showed you with a larger sample size in a pragmatic setting, and that we would actually have the power to detect that the difference in the advanced adenoma size detection was statistically significant. So we thought we would show this, and we thought we are going to move the lower tertiary performers, the people who I showed you in red, that I really want to nudge to better performance. We're going to get those people to improve substantially. So we put these devices in our Redwood City endoscopy suite. We had our other endoscopy suites as controls. We did not hide the fact that we had this, but we didn't advertise it either. We just wanted things to roll along. And then we also had our control periods of before the GI Genius technology was instituted. So what you'll see are now curves of before implementation, during implementation, both in the implementation site and in the parallel control sites where we didn't have the device. So the analysis ultimately here is a difference in difference analysis. How did one site with the device compared to the other? Total disappointment. The CAD-E site, you can see, is in the circles. From pre-implementation to implementation, no difference. The control sites that didn't have a new device, you wouldn't expect a difference, no difference. On the left side, adenoma detection rate, that high quality metric that I mentioned to you. And then another important one, adenomas per colonoscopy, because patients have more than one polyp, so you shouldn't be satisfied with just finding one. Some people have polyp multiplicity. No difference before and after with a device. So this is a big head scratcher. Why do our results differ from the randomized trials? And what about the results by tertile? So top tertile is the circle, triangle, middle tertile, bottom tertile is the squares. The people who are at the lower detection rates of performance, they didn't improve. So technology didn't fix our problem. Now, what I'm starting to think is that our main issue in terms of the operator dependence is not that the polyp is on the screen, which those are the only polyps the computer can see, or the ones that the human is showing the computer by actually showing that segment of the colon. I think our bigger problem is that a good fraction of colonoscopies may not be visualizing the majority, or I shouldn't say the majority, they are not visualizing some segments of the colonic surface area. This is a dynamic organ. We need to look behind folds. There are bubbles. There may be residual stool. There's fluid. You need to distend. You need to look behind. So the inspection technique has to be better. And I think that maybe the way that artificial intelligence will help us the most is if it can warn us real time, your mucosal exposure in that segment wasn't that good. Go back and look again. If we can be nudged into better inspection, then that may be the difference. I think it may be less likely that we're missing polyps that are on the screen. We maybe are just not even showing the missed polyps on the screen. Let's talk about novel tests, but a little bit of history first. So the initial experience with stool collection. I'll read you this. We believe it's important to remind those physicians who have not tried this system, basically of asking patients to bring in their poop, that aesthetically presents grave problems. Unless the office ventilation is better than perfect, the odor following the testing of several 3 or 4 day old stools will remain for hours. And so then what this entrepreneurial clinician did was to ask manufacturers to make special test slides that could be prepared at home. That's the origin of the Guaiac test. Remarkable. And this reminds me of Harry Truman's quote, there's nothing new in the world except the history that you don't know, because the themes are the same today. Do people want to handle their poop or not? Can we mail them tests to home? Same issues. So there's been a lot of enthusiasm. Can we do non-invasive testing that is not stool-based? And a lot of companies are investing a lot of resources in blood-based screening. And CMS actually came down with a statement saying, we will cover a test that has 74% sensitivity for cancer, which matches the FIT test, 90% specificity, which matches Cologuard. If you give us a blood test with these characteristics, we'll cover it every 3 years. So that specificity of 90%, that has become the de facto pegging point where the companies are developing their assays and they're saying, at a specificity of 90, what sensitivity can I get? And several trials are going to report soon by Guardant, Freenome, and Exact Sciences. The Guardant preliminary results are out, and these are them. You can see they pegged the specificity to 90%. At that specificity, cancer sensitivity, 83%. That is not bad. But I'm waiting to see what is the stage-specific sensitivity. We want to have early detection. So the stage 1 and stage 2 should be high for this test to be really good. The advanced adenoma detection is disappointing, and it's close to the false positive rate, right? At 90% specificity, you have 10% false positives. So you only have a 3% incremental detection of advanced adenomas. So this is going to be primarily, in this version 1, a cancer detection test, much less a cancer prevention test, because it doesn't find advanced adenomas as well. The Freenome data from a preliminary study is in the 90s for sensitivity and specificity. When you actually do the prospective validations, usually these numbers fall. We'll see where it all comes out. Now, you can't talk about blood testing without talking about multi-cancer blood-based testing. Maybe this will be the future. There's a lot of enthusiasm for the feasibility of doing blood tests that will pick up all kinds of cancers. But you can see all the potential issues here. What is the tissue of origin? To have a positive test for cancer is potentially a nightmare. What's the diagnostic odyssey? Where do you go? Okay, maybe everyone gets a PET CT, but do you do other things after that? It's potentially a big problem. Can we prove that we are improving clinical outcomes? That's a high bar. What about the psychological and emotional burden of a positive test, negative workup, walking around with a hidden cancer? And for colorectal cancer screening in particular, I'd show you how good the screening options are now with a so-called liquid biopsy that's multi-cancer with okay test performance characteristics, substitute for what we know works. I would say no. I think that's a disservice. So then you'd say, okay, here's your multi-cancer test, but then also do colorectal cancer screening on the side. And what about established breast screening? And people can, discuss the status of prostate. Cervical is well established. So this whole multi-cancer field, tremendously exciting, but very big questions. So I want to end with brief points on personalized screening. We think that one-size-fits-all approaches are not sexy. It's not the right thing to do. It's not precision medicine. So can we personalize things? Can we tailor screening to people? And there's a lot of enthusiasm here, but a couple of caveats. We actually modeled this. You have to make all kinds of assumptions, but we modeled this, and this is the summary of this complicated analysis. Consider two situations. One is where you have a perfect risk stratification tool and it's totally free. But then we get to reality, where you're probably going to misclassify a certain percent of people. I tell somebody, you're low risk, just get a one-time colonoscopy at age 60. You're high risk, start at 40 and come every 5 years. We're going to make some mistakes. Some of those calls are going to be wrong. And then this test, which may be a combination of biological and demographic things, probably not going to be free. So if the tool is perfect and free, the preferred approach is to personalize. But once you start getting into the imperfect world, one size fits all may be best. Maybe we just stick with average risk screening for everybody and make sure that people have access and actually do it. And the reasons are the following. When we overestimate risk, we overscreen people. That primarily increases costs. It increases risk a little bit, but it's not that risky to get screened. So overscreening has some benefits, some downsides clinically, but increases costs. If we underestimate risk systematically, that decreases prevention because we're underscreening people of a certain risk. So I'm enthusiastic about the potential of personalization, but I think the bar is very high. These prediction tools are going to have to be much better than they are today. So where have we been? I gave you a little bit of history, where we are. I showed you the evidence. I raised the next generation questions. And some of the big issues for the future are, is there a role for artificial intelligence in endoscopy? The novel tests are coming. These blood tests will be a reality. And personalized screening, I'm enthusiastic for, but we'll see where it goes. So these are the key takeaways. Colorectal cancer screening really works. The science is grade A, and the USPSTF recognizes that. The next generation questions then are about participation, quality, ethics, economics, equity. Colonoscopy quality is imperative, either as the primary screening test or as a follow-up to non-invasive screens. Artificial intelligence, I think, will find a role, but it's making its way. Blood-based biomarkers are coming, and maybe one day we'll personalize based on predicted risk. So I hope this was informational for you. Get screened, get your patient screened, and let's have some discussion.
Thank you, Yuri. There's a lot of positive feedback that this has been a very informative discussion. There are many, many questions, so I'll just try to summarize. A series of questions ask, how about cost? What's the cost effectiveness calculus in this? Because colonoscopy is perceived to be expensive.
Yeah, a good question. So various ways to look at this. Compared to nothing, all the options are cost effective, highly cost effective. As cancer care costs go up, some options are cost saving. Like if you just could do fit test and everyone did it, that's cost saving. But when you build in the navigation to get people to actually do fit testing over time, the way Kaiser does, not clear if it's cost saving anymore, but it's still highly cost effective. Now, if you start looking between strategies, what's more cost effective than somebody else? If everyone does fit, then colonoscopy is costly compared to fit, for sure. Cologuard is very costly compared to colonoscopy and to fit. And so then it all comes down to participation. And that's where you get nuance, because FIT with poor participation, high participation of colonoscopy compared to that is still cost effective. So in summary, every test compared to no screening is cost effective, maybe sometimes cost saving. There are some things that are more cost effective than others, but participation is a huge part of that specific calculation.
Thank you. That makes sense. Then there's a series of questions about social justice aspect for people who don't have access to this or the facility to get prepped appropriately. How do we make a dent in spreading this sort of a wealth to people who don't currently have access?
Yeah, so I think the best data here come from federally qualified health centers and other places that try to reach populations that are underserved, disadvantaged. I actually just learned something. I hadn't thought about this. There was somebody talking about populations of Native Americans, American Indians. You know, different people use different terms when they present these data. Some of whom live in places where they don't have mail, they don't have plumbing. So even the notion of outreach with fecal immunochemical testing mailed to your house and do this when you go to the bathroom in your house, that's a challenge even there. So in those extreme scenarios, I think it's very, very hard, and people are trying to do outreach in a community type setting. I would say short of that very extreme, if people at least have bathrooms and somebody knows in some setting that they're part of their catchment population, there are successes with outreach and navigation, with mailing, with reminders, with culturally competent and let's say culturally harmonious navigators. Those things can absolutely make a difference. And many times these people are volunteers. And if you talk about cost effectiveness, the investments in these things have tremendous yield. So if as a society we say we want to do this, I think we can get better. It probably won't eliminate the discrepancies completely, but we can make a very big dent.
There's some questions about bowel prep. So, you know, it's the most painful part of the procedure, if you will, for patients. So is there any innovation that's coming? And then what is the impact of poor bowel prep on ADR and other aspects of the procedure?
Yeah, so poor bowel prep, a disaster, and we can hem and haw all we want, but you need to repeat that procedure. So we don't want to be in a poor bowel prep situation because ADR is bad, we miss cancers, not acceptable. There are low volume preps. Some patients prefer those. You have to be careful with those in patients with advanced age, hypertension, kidney disease, or risk of kidney disease. But there are the lower volume preps. The splitting of the preparation, I think, helps. And there are the medium volume preps. Are there going to be breakthroughs where we say, oh, you know, now the prep's not a pain? No, I think, you know, there are the pill preps that have been tried over time. Are those better? I'm not sure. So I think what we need to do is flip things around and say, yeah, this is maybe not the best part of this procedure, but please do it well. It makes a difference in prevention. And if you get a clean prep, great exam, no polyps, you don't have to do this for another decade or maybe longer. By the way, the screening intervals may get longer because the colonoscopy seems to be predictive of low risk, if normal, for more than 10 years.
Let me nail you down a little bit there. So for people who don't think about this all the time, what is the go-to prep that you think that most people should prescribe?
So a good question. I mean, we still go with the standard PEG because it's the cheapest. The movie prep is in the middle, and then there are the lower volume preps, you know, like Prepopic used to be, Suprep. Those are okay in certain patients. So there's a range. I'm not sure that there's one that I would say is the best. You need to do a good split prep and get clean. And there are a few ways to get there.
Can you elaborate on split prep?
Split prep is half of the preparation the night before, half the preparation 4 to 6 hours before the procedure. We definitely see better then. If you do everything the day before, the right colon gets mucky, and that's where we were missing polyps and cancers more before, in the era of single prep day before.
I see 9 o'clock, but there are more questions. Maybe I can go a couple more minutes. So there are questions about how to use FIT. So if compliance is the same, do you recommend FIT, annual FIT versus colonoscopy? Can you provide a data-based answer? And then after a positive fit testing, what's the time frame for colonoscopy?
Okay. Excellent questions. So as of now, equipoised between FIT executed well every year versus colonoscopy every 10. The modeling studies would suggest that they're very, very similar. We don't know the answer, and that's why there are randomized trials. So there's a randomized trial of offering FIT annually versus colonoscopy at the VA, and there's a trial going on in Spanish centers. So those are going to be extraordinarily important studies. Standard of care after FIT positive to colonoscopy should be within 6 months. Once you start to get to 9 months or later, then the patients who get colonoscope have a higher rate of cancer, have a higher rate of advanced cancer compared to the ones who come in sooner. So I think that is the window. After 6 months, lesions start advancing. So get your patients in within 6 months.
I don't want to go on too far beyond the time frame that we have. So maybe we should wrap this up. What do you think, Bob?
I think you could probably take another 1 or 2. We often go to 9:05, Ray. I think that would be fine.
Okay. The other questions that come up is the relationship. What are the influencing factors of ADR? So are there sort of a multivariable things that we need to look at in order to interpret ADR data on an individual basis correctly?
So that's a good question. If I understand the question, is it like, oh, I scope mostly young, healthy women,
Exactly.
who mostly have older, obese men. At those extremes, yes, there's a difference. But the reality is that studies that have looked at this, for most people's practices, it comes out in the wash. And so these attempts to personalize my profile so that I can see where I should be, it moves people very little in the relative rank with respect to their peers. So that's why throw everything in, and for the most part, it comes out in the wash. But yes, the patient's characteristics do potentially make a difference. So polyp prevalence goes up with age, men more than women for a certain age, more with obesity, more with diabetes, more with smoking. Those are some of the risk factors. And by the way, those are some of the demographic factors that go into the risk prediction scores, but the risk prediction scores are bad. They're really bad. In fact, when a colleague and I wrote a piece on this one time, we said, okay, one of us scoped 2 people today. One was a 65-year-old obese white man. The other one was a 46-year-old, very fit, thin Asian woman who had the advanced adenoma. It was the younger woman. So, prediction is far from perfect. So that was just sort of a real world reminder of we're never going to be perfect in prediction.
Just to follow up on that, what about the provider side? What are some of the determinants of ADR, community versus academic, years of training, front training, volume?
That's a good question.
That, right? Yeah.
So as you can imagine, it's all over the place and one can't generalize, but in some of the series, younger trainees do better. They've grown up in this era, they pay attention. I think part of the problem is the older practitioners who may not have paid attention to this, who maybe feel a little defensive about it, maybe they don't have the same equipment. I don't think there's anything that is unchangeable, okay? There were some publications a while back, gastroenterologists are better than surgeons, okay? But that's just the training and the attention. Good surgeons are as good as the good gastroenterologists. So I think it's all changeable, and it's a matter of paying attention and trying to get better. I'm not sure what more I can say about that, because I don't think there's anything constitutive about people. Having said that, we all know that anything that's skill dependent, there are some people who are better than others. But I would say the average colonoscopist, if that person pays attention, they can get better and they can get to a very acceptable adenoma detection rate. And then it comes down to technique. So it's not the individual, but it's, are they deploying the right techniques to inspect well? And that's training.
The thorniest question related to ADR is, should you as a patient know what your doctor's ADR is? How do you share that information? Do you share that? Should we share that information? How do we do it in a way that is, I don't know, what's the right way?
Yeah, it's very difficult. I mean, I have had a few patients say, doctor, what's your ADR? and they've read, they've asked. That's very few of them. I'm happy to tell them I pay attention to this. I have a very high ADR, so I'm proud of that, right? Now, I showed you our scattergram, Ray. Those are you and me and our colleagues. Do we ever publicly disclose who's who? I don't want to do that for a whole variety of reasons. Although maybe we should. I don't know. This is an ethical question, right? But you can imagine people calling up for, I want to schedule my screening colo. Who's going to pick our lower detectors? I think it's on us to make sure that we don't have low detectors. That's why I was enthusiastic about artificial intelligence. But it didn't pan out. We got to keep working on it so nobody's a lower detector, right? But should patients ask? Yes. How do we publicly disclose? I don't know. We publicly disclosed our group numbers, which I think are good. I think I can say as a group, if you come to Stanford, you're coming to a high quality program. But within the program, do we have higher and lower detectors? Yes, so does everybody. Any group that has had the guts to publish this has their scattergram. And the question for the field is, how do we get everybody up?
Maybe we'll end on a sort of a futuristic notion. You mentioned a risk score. That's based on clinical factors. What about genetic factors? Can we sort of set this standard by having pre-procedure genetic information about their underlying risk?
Maybe. The latest data on a combination of our environmental risk score that has about 20 variables, polygenic risk score that has 60 some odd SNPs. The performance of that is an area under the curve of 63 or something like that, 63%. That is bad. In my mind, that is not good enough to risk stratify people. You make way too many mistakes. So we'd have to get better. And I think it has to be reevaluated dynamically over time. I don't think at 40, we're going to say, here's your gene score, environmental risk score. This is your screening program for life. It may tell you starting age. It may say you're high enough risk that you should probably get colonoscopy. Don't think about the less invasive ones. But then over time, the colon starts giving you information. Did that patient have polyps or not? And what types of polyps? And the predictors change. So to actually do dynamic risk prediction of the time and constantly adjust is the futuristic dream. Are we going to get there? I don't know. I'd love to think that we can, but I don't know what the true biology is. How predictable is it? And then you have the implementation challenge, right? Between that future where people do nothing because there's paralysis by complexity and just simple, stupid approach to everybody, but everyone does it, the simple one may win. So that's an existential question, complexity versus simplicity.
Okay, I think we're good, Bob. What do you think?
Yuri, this has been an absolutely fantastic rounds, grounded in science, really practical information, and your expertise in the way that you present the data was extraordinary. So thank you for joining us. I'm now going to keep the colorectal cancer screening background up for the rest of the day on the one of the last days of March here, and just remind all of us, both for ourselves and for our patients, that we need to be screened. So thank you, Yuri.
Thank you.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.